Hello, my geniuses. Welcome to another lecture series. Today is your great science tutor Lorenzo. Today we'll be talking about the manual muscle testing, or you can call it the manual muscle grading, or you can call it the motor power grading. Anyone that suits you, because everybody use the term anyhow. So manual muscle testing, manual muscle grading, or motor power grading, anyone. So this is just to check the strength of the muscle at that particular point in time, especially for those recovering from a post neurological complication, or somebody that have a lower motor neuron or upper motor neuron lesion. You always have a muscle deficit. Maybe their muscle becomes weak, or due to paralysis or flaccidity, anything that can cause the muscle to be weak. This is what we want to discuss today. How can you grade the muscle power? It's part of your neurological assessment, because we have done the GCS in the first time, so we are doing the manual muscle grading now. So if you are new to my channel, make sure to subscribe and turn on your post notification button, so at any time I drop any video, you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video for you. So we are talking about the manual muscle grading, or the motor power grading, extensively in this video. So make sure you wait to the last, because I'll be giving you a test clinical assessment question that we can use to work on this particular question. So let us jump right into the video now. So the first question we'll be asking ourselves, what is motor power grading or manual muscle testing? Are you getting me? Because I say it's part of the neurological assessment too, just like the GCS. So the motor power grading was a clinical method used to assess the strength of the muscle. So first of all, you have to underline the first one. It's used to assess the strength of the muscle and evaluate the functional integrity of the motor system. Again, now if I take it again, it's a clinical method used to assess the strength of the muscle and evaluate the functional integrity of the motor system. Because one thing you have to know, after a post neurological complication, maybe from an upper or a lower motor neuron issue, what happens? Sometimes the motor system is usually disrupted. If the brain is not damaged, or maybe it's not a stroke or any issue, if it's just a nerve issue and not from the cortex, usually the motor system is usually spoiled. And once the motor system is damaged, now the motor function, which is the muscles, the ligament, the joints, begins to have issues. So you'll not be able to use your muscles again. So before we start prescribing exercise, or before we start giving some drugs, or to do some surgeries in order to recover this muscle, we have to first of all grade the muscle. So we'll know the grading system which we use to grade the muscle by the mid part of this video. So he says it's a clinical method used to assess the strength of the muscle and evaluate its functional integrity of the motor system. It helps to detect weakness called or paresis. So paresis is a medical term for weakness, or you can use it to detect what they call paralysis. So what is paralysis? Paralysis is plegia. So why weakness is paresis, why paralysis is plegia. So it's used to detect weakness, paralysis, nerve injury, which you call neuropathy, or we have spinal cord lesion, maybe when there's any damage to any part of the spinal cord, or you have stroke, which is a upper motor neuron lesion, or a neuromuscular disorder. Maybe the patient has a persistent, maybe congenital neuromuscular disorder that came from birth. So any of these will cause the muscle to be weak. It will cause the muscle to be weak. So these are conditions. It's either from the upper motor neuron lesion, which is from the brain down to the spinal cord, or a lower motor neuron lesion from the spinal cord out to the external muscle, ligament, and joint system. So it could be from weakness, paralysis, nerve damage, spinal cord lesion, stroke, neuromuscular disorder, and MKD, which is musculoskeletal disorder. Any of these can cause weakness of the muscle. So all these things I'm trying to explain to you, very, very simple. So now, based on the one that is widely used, the scale that is widely in use, because the one I gave you for the GCS, I told you about the eye verbal response and motor response, and I give you the grading from there. So this one, to the most widely one we have that's always in use, is the MRC. So what is the MRC? The MRC is the Medical Research Council. So the Medical Research Council gave a scale, and the scale is from 0 to 5. So we also call them the Oxford Muscle Grading. So the Oxford Muscle Grading, it was simulated by the Medical Research Council. So they gave a grading from 0 to 5 to determine the muscle power. So they graded it from 0 to 5 to determine at what point in which the muscle power is. Same as GCS, this one is also used for for a functional outcome measure. Functional outcome measure in the sense that after a patient comes out with a muscle power 0, maybe the muscle power is paralyzed completely, and after you have treat him or the patient for a long period of time, then you assess with the muscle power to see whether you are improving or not improving. Are you getting that? So you should always know that it's a clinical tool used to check the strength of the muscle and the integrity of the motor system. And the one we use is the Medical Research Council giving the Oxford muscle grading, which is from 0 to 5. So the question here, why do we test the motors? The question here is, why is the motor power tested? So why do we test the motor system? Why do we test it? One, to identify neurological deficit. Which means whether there is any cortical damage, especially from area 4, area 6, or area 312. Area 4, area 6, area 312, because these are where our motor signals are originated initially. Area 4, area 6, area 312, which is the primary motor cortex, the premotor or supplementary motor cortex, and the primary somatosensory area. So, or whether there's a lesion in the basal ganglia, or whether there's a lesion in the cerebellum. So, or any of this pathway we are using to check for any neurological deficit. Two, we have to localize the lesion to know where it is affecting really. Number three, to monitor disease progression. I told you to monitor disease progression using it as a functional outcome measure to track whether you are, as a clinician, you are doing the right thing or not. The next one, to evaluate recovery after treatment to see whether the patient is also improving, and also to compare strength between limbs, because maybe the patient can have maybe right arm weakness or right upper limb weakness and the left arm is good. So you across time, or the right arm weakness is having a muscle power of like 3, the left arm is having a muscle power of like 4. So you have to compare across time, because you have to treat them equally. And the last one, to guide treatment and rehabilitation. So everybody uses this scale, whether a medical doctor, whether a physiotherapist, whether a nurse, any clinician. You could use the manual muscle testing to grade the muscle power of any patient, because from there you will know which muscle is affected. First of all, we pick out the muscle that is affected, we isolate the muscle, we know what is happening to the muscle, and we look for a way to manage the patient functionally. So one thing you have to know here is that the manual muscle test is a good grading system in order to evaluate the functionality of every part of the body. Are you getting me now? Especially the muscular system itself. The muscular system, not even the joint, because in the joint you have that scale to use for the joint. You have what we call the range of motion grading, how to use your your goniometer to measure the joint angle. So that joint own is different, but for the muscle, to check the muscle integrity, you need the manual muscle testing or the Oxford muscle grading to grade them. So since you have understood this one now, so it will give an overview of the muscle power scale, or we call it the muscle power scale, or we call it the Oxford muscle grading, or we can call it the Medical Research Council grading. Okay, now so I'll just give you an overview of all these things, then we'll not talk about them one by one, because I want you to understand it and know the reason why. It's not just knowing how to do it. As a clinician, you have to know the skills, you know the method, and also know how to apply it, and also know when to switch from one part of treatment to another based on the muscle power you're seeing. So that's why I'm teaching. I want to teach it one after the other. First of all, it's graded from 0 to 5. It's graded from 0 to 5. What does 0 means? 0 means no visible contraction. The patient is just paralyzed. The patient, there's no interaction, no neuromuscular transmission at this particular point in time. No neuromuscular transmission, because neuromuscular transmission is when the presynaptic membrane releases acetylcholine. Acetylcholine is released to the postsynaptic membrane, binding to the receptor, so that there will be contraction. So at this particular point, there is no interaction between the neurons, which is the nerve that is innervating it, and the muscle. So there's no neuromuscular transmission here. So there's no contraction, no visible or palpable or muscular contraction here. This shows what we call complete paralysis. When a patient is muscle power 0, we'll talk about it extensively. So the next one here is 1. When you see 1, that means there's a flicker or there's a trace of contraction. You get it? It's a flicker. At least you can see some twitches, as the muscle might be twitching at some particular point in time. So either if the patient is moving a finger, at least the patient is moving a finger and there's no complete paralysis at that particular point in time. So there's slight muscle contraction present but no actual movement. The muscle is contracting. You can see a flicker of contraction, you can see a twitch occurring, but there's no muscle. The patient is not initiating it by themselves, it's just the body doing it. So here the muscle fiber are contracting but the strength is not sufficient to move the limb. So number 2 shows that what there's active movement with gravity. So where there's active movement with in line with gravity, so gravity is not used here. Are you getting now? Gravity is not moved here, used here. Are you getting now? It's just moving your hands in line with gravity. So I will give you an image so you see how somebody can move in line with gravity. Are you getting now? You are not moving the hand up and down. Up and down, if you are moving the hand up, you are moving the hand against gravity, but you are waving it like mid-air, like you're just waving it side to side. You're just waving the hand side to side, but you are not moving it up and down. Because when you move it up, you are doing it against gravity. If it's your leg, you are taking your leg up, you are not taking it side to side. So if you move your leg side to side, you are moving it in line with gravity. But when you move the leg up and down, you are moving it against gravity. So I'll be showing you some image where you use to get where it's in line with gravity and where it's in line against gravity when I talk about them extensively. So here the muscle can contract enough to produce a movement. The muscle can contract enough to produce movement, but it cannot do it against gravity. You get it now? So for 0 there's no visible contraction, complete paralysis. For 1 there's a flicker of contraction, there's movement, but the patient do not have strength enough to move that limb. So the next one is 2. Here the patient can contract the limb enough but cannot do it against gravity. So in 3 now, the patient can do active movement against gravity. So the patient now, or the individual, can raise his hand or his leg up and down, or raise the head up and down, or raise the body up and down. Are you getting me now? Because when you are going up, you are doing it against gravity. Are you getting me now? But when you are moving it from side to side, you are doing it in line with gravity. So now the next one here is number 4, which is the active movement with resistance. So when you add resistance to it, maybe you are using a TheraBand or the therapist is applying pressure in the opposite direction to the one the patient is doing. Maybe the patient is flexing the upper limb and a therapist apply pressure downward, preventing the patient to raise his hand. So if the patient can do it against gravity, which means the patient will be given a 4. So here there's mid muscle weakness at this particular point in time, but the muscle is contracting enough to produce what? To counter what? Gravity. Enough to counter what? Gravity. So when you give the patient 5 is when the patient have full strength. The patient have full strength and the patient is doing it against gravity, and it can do it in line against gravity, and there's always full muscle action. There's always full muscle action here. So you can say number 1, complete paralysis. Number 2, there is a flicker or trace of contraction, but it's not enough to produce a visible movement. 3, you can only move the limb in line with gravity, which means you cannot take it up and down, only side to side. Number 3, you can take it against gravity, but you don't have strength to put it to resist resistance. Are you getting it? You don't have a strength to resist any force in the opposite direction. In the 4th one, you can resist the force in the opposite direction, but you can only do it minimally. Then the 5 is that you have a normal movement. Are you getting now? The important thing to notice is that always assess both sides when you are doing the treatment. So you have to assess both sides. You don't just do one side, you do at both sides. And when you do it at both sides, you always grade them and write what you see down. You get it now? And 0 is the best, 0 is the weakest, while 5 give us the normal and greatest strength. 0 is the weakest, 5 is the best. So the next one, now we want to go into this grading one after the other. So in the first one, I just give you an overview of the manual muscle grading, but this one I'll be going into one by one with pictures. So you'll be seeing pictures there and how to examine the patient that is having any of this stuff. So next we'll be talking about the Oxford muscle grading one after the other and how to assess them, because in the last one I just gave you a summary of all of them. But here we'll be looking for how to assess. I'll teach you how to assess, and when you see a patient like that, what will you think about? What will be your first mode of mind? What will you think about? What will be your differentials? What will you know it is the cause of it. So number one, if a patient have a muscle power of 0, what should be in your mind? Remember, muscle power of 0 means there's no visible contraction. There's no movement, there's no palpable muscle activity. You are not seeing anything with muscle power 0. And what should come to your mind? What is the clinical meaning of no contraction? Number one, there's complete paralysis of the muscle, which means neurons are not transmitting acetylcholine, which is binding to the nicotinic or muscarinic receptor on the postsynaptic membrane, which is the muscle. So there is no neuronal transmission, there's no neuromuscular transmission at that point in time. Something is occurring that makes the nerves not to release acetylcholine to the muscle. It could be any clinical condition that is causing that. Now, what are the common causes? The common causes could be complete nerve injury. It could be that the nerve is injured, causing neuropathy. It could be a severe SCI, which is spinal cord injury, maybe transection, bone squeeze. It could be lateral damage of any part of the spinal cord. It could be advanced stroke, which damage the cortex of the brain, could be anoxic brain injury. It could be clot in the blood vessel. It could be hemorrhagic. It could be anything that is causing the advanced stroke. Or it could be a lower motor neuron lesion after the nerves have left the spinal cord. It could be compressed in any part. Any of these can cause the muscle power to be 0. And how do you elicit it? You elicit it very easily. You are looking at your screen. You ask the patient to move his hand while you observe for any palpable movement. So you ask him, sir or ma, lift your arm for me. Lift your arm for me. So when you tell the patient to lift their arm for you, you could watch them do it. Just allow them do active movement. You not help them for passive movement. You allow them do the active movement. So now, what will be the result if there is no muscle movement? You will see that there will be no contraction felt in the muscle, and the patient cannot move the joint. So now, example now, patient try to lift his wrist but no contraction is seen. So you tell the patient lift your wrist and the patient could not move it. Are you getting? Now this will suggest damage to the motor pathway of the muscle, which means the connection between the brain and that muscle is out. So you see having a muscle power 0, because muscle power 0 means no contractions. Now muscle power 1. What does muscle power mean? There is a flicker or there is a slight movement of the muscle, but it's just that the patient is not aware of it and the patient cannot use it to do anything. So there's slight muscle contraction present but no joint movement. The patient can just wiggle. It could be a twitch. The patient can just wiggle the fingers. The patient can just move the arm, but the joint is not obeying it. It's just a little amount of transmission that is occurring in the muscle at that point in time. So flicker or trace of contraction. So this will be a slight muscle contraction is present but no actual movement. A slight muscle contraction but no actual movement. And what will this tell you clinically? It should tell you that the muscle fibers are contracting, but there is no recruitment of more muscle to perform a definite movement. Because before you move, there must be recruitment of more motor units. That more motor unit will facilitate contraction. So but this one is just single muscle fiber acting separately on their own. I get him now. So the muscle action that is contracting is insufficient to produce a definite movement. So you should know that. So how to examine it? So what you tell the patient, you palpate the muscle or the tendon while asking the patient to attempt the movement. I get him now. So you hold or palpate that muscle. If you are telling the patient to flex the elbow, you palpate the bicep brachii and the brachialis. You tend to palpate it because as the patient does the movement. Are you getting him now? So you tell the patient, try bending your elbow. You tell the patient, try bending your elbow. And when the patient tries to bend the elbow, you see that the patient try to raise his arm up to bend the elbow, but the slight bicep contraction is felt. So you tell the patient to try flexing your arm, try moving your arm up while the patient is lying on the bed. You tell the patient, try moving your arm up, and the patient try to move the arm up. The patient will try, but it's just that the patient can't really do it, but you see that the patient is trying. Okay, now, so that is what will happen. So what will you feel when you are palpating the muscle? A slight tightening or flicker in the muscle, but there's no movement. So you'll be feeling that the patient is trying to do it, but the muscle the action is not really being done, because maybe the patient cannot use that muscle to facilitate movement of the joint. So that is number one. What will this indicate for you? To indicate that there's severe weakness, but there's nerve supply, so there's innervation. In the first one, there's denervation. In the first one, there's denervation of the muscle, but in the one, there's innervation of the muscle. Then that innervation of the muscle shows that nerve is the neuromuscular transmission, but the muscle is weak. There's not enough acetylcholine needed to facilitate muscle contraction. You get it now? So I want you to note it and don't forget it. I want you to note it and don't forget it. Now in the muscle power 2, which means that the patient can actually move the limb in a gravity free plane, which means the patient cannot move it against gravity. Get it now? So you have to remove gravity, maybe making the patient wave the arm side to side, moving the arm or upper limb side to side or the leg side to side, but the patient cannot bring it up. They can only wave it side to side but cannot bring it up. So there's active movement side to side, but you have to eliminate gravity. So because the patient cannot bring it up and down, he can only move the limb side to side without up and down. So now how can you describe this to the baby? Now, this particular point, patient can move the limb when gravity is removed from side to side. Are you getting now? But the patient cannot move it up and down. It can only move it side to side. So what can this tell you? The muscle contract enough but not to overcome gravity. In the first one, the muscle cannot contract at all. The muscle cannot contract because in the first one, the muscle cannot contract because it is denervated. There's no neuromuscular transmission at that particular point in the first one. In the second one, the muscle is innervated, but it's just that the muscle fibers are contracting separately, so the patient can produce a contraction, but the contraction is not enough to produce what movement of the joint. In the second one, the patient can move the upper the joint, the muscle and the joint very well, only from side to side, only when you remove what gravity. So that is what you tell you now. How will you tell you now? The patient will place the arm on the chair, and if they place the arm on the chair or a bed rest or a table rest, the patient will now be told to now move the arm in a horizontal plane. That means from side to side. The patient will be told to move the arm from side to side. Now the patient can slide. Now what will happen now? The patient can slide the arm across the bed, right, on the bed, not above the bed, not up and down. The patient will be able to slide it from one side of the bed to another without bringing it up. This shows you that the patient cannot move it against gravity. Cannot move it against gravity. So what will you see? There will be movement in the supported position, which means there will be movement in line with gravity but not against gravity. That's what you see. There will be movement in line with gravity but not against gravity. So and now what will this clinically tell you? The clinical indication that there's moderate to severe weakness. There's the innervation. I get him now. There's the innervation. You get it now? So it's just that the patient cannot move it above. He can only move it from side to side. Can only move it from side to side. In the first one, there's no contraction. Second one, there's trace of contraction but there's no movement. Second one, there's a movement only when gravity is removed from side to side but not up and down. Now in the third one, now the patient can contract the muscle enough to move it up and down. The patient can contract the muscle enough from side to side. The patient can contract the muscle enough to move it up and down. And if the patient can contract the muscle to move it up and down, what will happen now? What will this show? That patient can move the limb against gravity, so up and down. You can move it against gravity. Now cannot overcome any additional resistance. The patient can only move it against gravity, but when you add resistance, the patient cannot overcome that. So it's a step by step. In phase 0 or in grade 0, what happened? There is no contraction. The muscle is denervated. Muscle is denervated completely, so there's no movement, there's no neuromuscular transmission. In the first grade, what happens? There is a trace of contraction. There's a trace of contraction there, but the contraction is not enough to move the muscle. I told you how you do is that you palpate. When you tell the patient to perform a particular action, then you palpate the muscle the patient is using to perform that action to see whether there's contraction. So there's contraction, but the patient cannot still do it. In muscle power 2, what happens now? The patient can only move it from side to side when gravity is eliminated, from one side to one side, but never up and down. In the third one now, the patient can move the arm up and down, but when you add gravity, the patient cannot do it. When you add gravity, the patient cannot do it. So first of all, the patient can only move the arm arm or leg or any part of the body against gravity, but not when additional resistance is added. So what does this clinically tell us? It clinically tell us that there's moderate muscle strength. So there's moderate strength there. So patient can raise his arm up in the air. The patient can raise his hand up in the air, like you are seeing this patient now, but when you apply pressure, a patient cannot do it. Okay, now, so ask the patient now to lift the arm against gravity. So like you are seeing this picture now, you tell the patient to move the arm up. Please, sir or ma, lift your arm up. Now when the patient lift their arm up, what do you see? The limb move against gravity but gives way when and any addition resistance is added. So it will give way when you add resistance. Give way in the sense of the patient will not be able to resist you or resist the therapist or resist any form of resistance that is added. So how we test for resistance now? Apply a downward pressure to it. You apply a downward pressure to see whether the patient can cope with it. If the patient cannot cope with it and can only move it against gravity, which means you give the patient 3. So clinically, what will this tell you? This suggests that there's weakness, but some motor points are intact, which means some motor units are being recruited enough to make the patient move it against gravity. The fourth one now is that the patient can move it against gravity and can only support it with resistance too. So the patient can move it against gravity, and when you add resistance, the patient can also go against that resistance. Like the patient can oppose the resistance. So if you add the resistance to it, the patient will oppose it 100 times. So now what is the description here? Patient can move the arm against gravity and can overcome resistance when additional strength is added. You get that? So the patient can overcome resistance, but it depends. So you now, being the therapist that is applying resistance to the patient, you will now check whether the resistance, whether the patient is trying to overcome it strongly or is trying to overcome it weakly. If it's trying to overcome it strongly, which means you give them a 4+ or so, and the patient is trying to overcome it but not really doing well, you give them a 4-. So it depends on whether it's a plus when the patient is doing well or a 4- when the patient is not doing well. Now this shows you a mild muscle weakness, but in muscle power 2, this shows you a severe, not a moderate to severe muscle weakness. Like I told you, a moderate to severe muscle weakness, while muscle power 3, a moderate severe muscle strength and muscle weakness, but the weakness is not there, but it's also still, at least it's still showing. Why in muscle power 4 there's this mild muscle weakness? The weakness is not that strong because the patient now can do it against gravity and can also overcome resistance. So pressure patient can resist pressure, but the strength is less than the normal side. So the strength is less than the normal side. So now you ask the patient to hold the limb in position. Ask the patient to hold the limb in position while you apply resistance. Like now you tell the patient to put his arm up, like you are seeing it now. Are you getting now? So let him hold his arm in elbow inflection. So when you hold the elbow inflection, then you try to push the forearm. So where the therapist is about to hold is the forearm. So when you hold the forearm and you draw the forearm away, if the patient try to resist the therapist's hand, which means that limb is getting stronger. That limb is getting stronger. So what will you observe? The movement will occur, but the patient's strength is weaker than normal. Are you getting now? There will be movement. The patient will try their best to overcome that muscle weakness. The patient will try to overcome the therapist's hand, but you still see that there's muscle weakness there. You get it now? On the affected side, it will yield pressure, while on the normal side there will be strong opposition to that therapist's pressure. Like when the therapist is about to apply the resistance, the person will put up a strong show there. The patient will, so if resistance is added and the patient cannot resist it that strongly, you give them a 4. But if the patient can resist it that strongly and to you it is okay, you give them a 5. You get it now? But if the patient can resist it that strongly but not enough to give them a 5, you give them a 4+. So it depends on your clinical judgment and the one you feel that is nice. Now this is indicating a mild weakness, maybe due to neurological, muscular or pain related conditions. You get it now? So in muscle power 5, this is showing full strength. It's showing full strength and the patient can move it against gravity and resist the resistance added or any load added to the patient 100 times. The patient will resist it 100 times. Are you getting me now? So how do you describe this now? Patient can move the limb against gravity and overcome full resistance applied by the examiner or the therapist. So this indicates a normal muscle function. This is a normal muscle function because now this ability to use your hand to carry out normal daily activity. Now, patients strongly resist the pressure without any weakness, so you don't see any weakness there. Are you getting me now? So you still do the same thing. Are you getting me now? You do the same thing and watch how hard the patient will resist the therapist hand or the examiner's hand. How hard. If the patient is doing it weakly, a 4. If the patient is doing it strongly, a 5. Are you getting me now? If the patient is doing it weakly, a 4. If the patient is doing it strongly, a 5. Now the limb maintain a what position firmly against what strong resistance. This is what I've said now. And what will this indicate to you? To indicate a normal motor or strength and the what motor function. It will indicate a normal muscle strength and a motor function. So which means the limb is intact and there is no problem. Are you getting me now? So a quick reference to what we have said: muscle power 0, no contraction; muscle power 1, flicker or trace of contraction; muscle power 2, active movement with gravity being removed side to side; 2, active movement against gravity up and down; 4, active movement when we add resistance. So the patient can move it up and down, but I apply resistance, the patient will be able to overcome. Then 5, normal power. So there's, even though the patient resists it very strongly. So now tips to know, give an accurate grading. Explain and demonstrate the movement first to the patient before the patient do it. So you do it by yourself, tell the patient what you're about to do, and you beg for the patient full cooperation to do it, and also encourage the patient while the patient do it. Ensure patient is comfortable and cooperating. That's why I say you explain it to the patient and make sure the patient, and you encourage them that they can do it even though the patient muscle is weak or the patient is giving up. You also encourage the patient. Compare both sides. When you do one limb, you do it for the other limb too. Use consistent technique and similar positions. So you use one technique all through the range of motion. Are you getting me now? You show the patient so that he gets confidence that he can do it, and dominate and document the grading. So if you get 3, you write 3 over 4. If you get 3, you write 3 over 5. If you get 2, 2 over 5. If you get 4, 4 over 5. If you get 5, you write 5 over 5. You don't just say 4 muscle power 4 muscle power. You do it over 5. That's how to grade it. Are you getting me now? Now, common muscle group that you can test. First of all, in the upper limb, you check for all movement in all joints there, in the upper limb. So now, in the shoulder, you have 6 movement you can check for. You can use flexion, extension, abduction, adduction, and maybe medial rotation and lateral rotation. Are you getting me now? In the elbow, you can check for flexion and extension because that is the only thing that the elbow can do. In the wrist too, you can check for flexion, extension, ulnar and radial deviation. And you can also check for grip strength in the wrist. In the lower limb, you can check for hip 6 movement: hip flexion, extension, abduction and adduction, medial rotation, lateral rotation. In the knee, you can check for flexion, extension. In the ankle, you can check for dorsiflexion, plantar flexion, inversion, eversion. Are you getting me now? In the neck too, you can check for flexion, extension, side to side movement. Are you getting me now? So what are the clinical pairs here? The manual muscle grading or the motor power grading helps in what? Dictating weakness, localizing lesion, like I said in the beginning, monitoring recovery, planning what rehabilitation, and evaluating treatment what effectivity. Are you getting me now? For you to know whether the muscle power is weak, you have to grade it efficiently, and when you are now treating the patient, after like 3 to 4 treatment sections, you will reevaluate again, and it helps you to localize which part of the muscle is being affected. It makes you know which part of the muscle is affected at that particular point in time, and when the muscle is affected, then you can now go in and work on the muscle very, very well. Are you getting me now? So always remember how to examine the muscle power. You explain the procedure to the patient. I told you, tell the patient what muscle is about to occur. Now you compare both sides. Are you getting me now? You compare both sides, then you position the patient properly. And make sure that now there are so many positioning which we'll do. Normal positioning, how you can position a patient in lying, in standing, in sitting. We call it what? Fundamental positioning, and we'll do it in this channel. Fundamental positioning. So you position the patient very well, ensure the patient is comfortable, the joint is free, and gravity is properly used or eliminated. Are you getting me now? So apply pressure when needed. So when you're applying resistance or pressure, you apply it when needed to assess the patient's strength, and you have to grade the response like I told you. If it's a 3, it's a 4, you do it over 5. So I hope this all made sense to you and you have understood everything I've talked about in everything I've done and everything that we have talked about. So I hope I've explained everything to you and you have watched the video up till now. So I've given you the breakdown of how manual muscle testing is and how you can grade them by yourself and how you can use it for a clinical practice. So if you are new to my channel, make sure to subscribe and turn on your post notification button so that anytime I drop any video, you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video solely for you. So now I'll be going to my next video, which is the upper motor neuron lesion. So we'll talk about the upper motor neuron lesion, talk about the lower motor neuron lesion, then we'll now continue on other clinical topics that be important for you for your clinical practice. So I'll next see you in my next video. Bye bye.